Chief Fellowship Director and the Powerhouse Endowed Chair of Pediatric Rheumatology at Baylor College of Medicine. He received his MD from Jefferson Medical College and did his medical training at Children's Hospital Pittsburgh, followed by fellowship at Baylor. His research interests include neurologic manifestations of systemic autoimmune diseases, including SLE, autoimmune polyneuropathy syndrome, and vasculitis and autoimmune encephalitis, and holds a co-appointment in Division of Child Neurology. He's going to be speaking on biologics for neuroinflammation. Are we ready for precision medicine?
Thank you so much for that lovely introduction. I'm really honored for the invitation, both from the Children's National and NIH Organizing Committee, though it is sort of making my imposter syndrome go off the page as I followed some real experts. And hopefully, I think of this as more of a tapas, sort of small plates. 20 minutes is not enough time to really touch upon all these aspects. I think I'm going to ask more questions and provide your answers. And I think for this kind of symposium, I think that's okay. I have no disclosures. There are some of my evidence-based topics, including a really lovely review that Dr. Wells co-wrote a couple years back. All right, and so what do I want to have accomplished by the end of our time together, which will go by immensely fast, is I want you all to be able to have a rational approach with which to tackle neuroinflammatory targeted therapies. I think you got some of that from a couple of speakers before me, both in terms of molecular mimicry, HLH care before that, how do we use CSF studies, and I'll touch upon, obviously, the biologic therapies that we currently use in rheumatology, how some of those can be repurposed in this day and age, and where we might be going on the horizon if we work together. And lastly, my biggest plug is that we find ways to share expertise with each other and work as teams. I'm not sure I have all the right answers on how to do that, and I think every institution's team-based care is different, but I do think we all have so much to teach ourselves. And end of the day, especially a critically ill child in the ICU with neuroinflammation really deserves sort of our full court press. As you can tell from behind me, I'm a big basketball fan. Now, what are some of the barriers to care? So as a rheumatologist, truly being a stranger in the strange land of neurology, some of that's understanding how our medications work, whether they get into the CNS parenchyma, whether this is about dampening inflammation outside of the CNS, or are we dealing with cells that live inside the CNS? I think some of us that are not in rheumatology and immunology will use certain immune dysregulatory terms interchangeably. And obviously that will not assist us if we're dealing with B cell process and we're using medications that more target the innate immune system. I think some of you in the symposium that are entrepreneurs and are lab-based individuals, we are really lacking in point-of-care diagnostics as outcome measures for whatever dampening approach that we take. And then lastly, really, I think the only good thing about the pandemic for medical institutions is that silos of care have been broken down. I think MISC and COVID hyperinflammation has done a good job of bringing us together. And indeed, if we use the analogy of walking on the beach, most of the time we walk in different directions. And I think neuroinflammation really allows us to ensure that we come together. Now, whenever I do get a phone call to go to the ICU to take care of someone with neuroinflammation, I sort of feel like a child who has, 2,000 Lego pieces there right in front of me, and you don't know where to start. And though in your head, you might have where you're getting to there at the end with sort of this lovely stick figure. But if we sort of think of the way we always take care of a patient, how do we link together mechanisms, phenotypes, diagnostic measures, and then treatment approaches? And obviously, these are all linked together like a chains on a chain link fence. But if we think of that scaffolding, we can often sort of make more sense of a sick child, especially in the ICU. Now, I'm a rheumatologist, so even though I have a co-appointment in neurology, all my work is taking care of patients with immune dysregulation and rheumatic diseases. I am not a boarded immunologist, but I do use some of these big terms as a way to think of the immune system and the medications that I know how to use at my discretion for other disorders. And I try to bring that knowledge to the bedside as we think about neuroinflammation. And you've heard some of this already. I really hope that my talk is more complementary than redundant to you, and maybe it builds upon some of the talks before me. As we think about the adaptive immune system, we might have humoral immunity, and I'll talk about Rituxan-B briefly. As we think about more cellular-mediated dysfunction, I'll briefly talk about blocking downstream effects of tumor necrosis factor alpha. And as we talk about autoinflammation or the innate immune system, I'll briefly talk about two of the medications at our discretion as rheumatologists that we can repurpose towards neurology. I'll have brief cases for each type of immune dysfunction, but I will not go into things in as much specificity as previous speakers did. Again, I'm here to whet your appetite and hopefully get you excited about where we're going in the future in this field. Now, as I get older, I've always wanted to say I'm just an old country doc. Unfortunately, I'm a pretty subspecialized rheumatologist, so whenever I say that, my fellows roll their eyes at me and think that it doesn't really go very far. But over the years, as I've heard about the blood-brain barrier, things have definitely evolved. And I realize that my knowledge of the topic is really rudimentary. So as we see a picture from about 12 years ago, you have your tight junction, you have some of these other cells, which I'm sure previous speakers talked about. But as a rheumatologist trying to support the mission of intensivists, neurocritical care doctors, and neurologists, this really isn't good enough for me. Now, I think we've learned a lot about CNS dysfunction during the pandemic. So this is a picture that's that potentially has some of those bells and whistles. Rheumatologists are very comfortable thinking about the periphery. We're also very comfortable thinking about vascular dysfunction and inflammation, whether that's lupus or other disorders. But we really aren't trained to think about oligodendrocytes or astrocytes or microglia. Obviously, it's great that this picture, unlike the previous one, has cytokines. And many of these are ones I know how to target, as I'll talk about in a couple of minutes. Yet even that's not good enough. As we all know, medications that rheumatologists and immunologists and neurologists use may not have access to the CNS. And I've had to sort of educate myself a little bit or ask many of you questions who are neurologists on how do we get drugs into the brain? Does it matter whether the blood-brain barrier is disrupted? It definitely does in other disorders I take care of, such as lupus. Do we need certain tricks? We all know that small peptides can get access, but not so much large medications, as I'll tell you in a second. Cytokines have ways to get into the CNS, and obviously some of this is also on whether a medication is lipid soluble. But really what I need as a rheumatologist to support this mission is a picture like this. I need to know which medications are currently in play and where they actually function. So as we think of the various medications up here, they have to do with B cells, they mostly act in the periphery. As we think about interleukin-6, and I'll talk to you about that in addition to Th17, again, they might be in the periphery. Then we know that certain cells can infiltrate the CNS or the CSF, and then certain medications I'll talk about sort of on the horizon can actually make their way into the parenchyma. And obviously this is much more helpful for me as a rheumatologist. Sticky finger here. For some reason, it's not letting me go back. All right, so real briefly, as a rheumatologist, I would love to know, can we understand what's going on in the blood-brain barrier? We can, certain tools such as MRI, and then in other disorders and in research, a sense that certain cells can lead to damage. And perhaps in the future, we can get a sense of which medications will get into the CNS or which ones are only work in the periphery. So a really quick case, 12-year-old girl, psychosis, cognitive changes, delusions, eventually ends up in a hospital with seizures and coma. And indeed, this is a case, though I thought it was lupus, a girl that really changed my life professionally in terms of being the first kid with NMDA I ever saw. One of the most intriguing conditions, as indeed antibodies don't just lead to inflammation and damage, but they take neurotransmitters offline. Now, as many of you know, standard of care is often depleting B cells, but rituximab is mostly a peripheral agent. It's quite large. It actually barely penetrates the blood-brain barrier unless you have immensely active leptomeningeal disease, although this data is mostly in CNS lymphoma. Now, if someone does not respond to Ritux, can I bring other tools or knowledge as a rheumatologist? Is this because of an excess of interleukin-6? And I'll talk about some of those agents later when I talk about the innate immune system. Is that the fact that rituximab only works on mature B cells? And indeed, plasma cells also make antibodies, and rituximab will not get at that. And obviously, the immune system is not compartmentalized. So we have T cells, macrophages, microglia, all perhaps cells that we're not getting at so much by targeting just B cells. Now, unfortunately, since many of us have different skill sets, not that many immunologists or rheumatologists are involved in NMDA receptor encephalitis. Can we bring some of the tools or some of the ways we think about lupus to the neurology bedside? And indeed, I think we can. You've heard some of this in the previous talk regarding MS and CSF biomarkers, but could we get at B cell biomarkers a little bit better? Some of the cytokines that are B cell associated or activity factors. And indeed, could we have a sense in advance in terms of risk prediction? Who is going to fail a certain medication or who needs certain medication from the get-go? A much more precision medicine and one might say personalized medication approach that you've heard is obviously commonplace in many disorders. Now, as we switch gears quickly to other disorders, so more thinking of cellular-mediated immunity. Again, another real case, 7-year-old child, headaches, confusion, emesis, seizures, obtunded ICU with a pretty terrible MRI, which was thought to be probably related to malignancy. And unfortunately, lo and behold, he's got a lymphocytic small vessel vasculitis, so primary angiitis of the CNS. Though one might say that this could have gone a different way. As we think about parenchymal inflammations, this could have been Rasmussen's, or if there are other features of white matter disease, fulminant ADEM, and acute hemorrhagic leukoencephalitis. And indeed, this talk is not meant to be comprehensive. The differential here was quite larger and involved other entities that were not inflammatory. But as we think about Rasmussen's, or acute hemorrhagic leukoencephalitis, or CNS vasculitis, there are a variety of cells in play, not just obviously antibodies, T cells, though there is obviously a B cell story which keeps waxing and waning in Rasmussen's, and then again, potentially neutrophils and not just T cells in sort of fulminant acute onset of demyelination. Most of these severe cellular-driven inflammatory conditions will often have old school chemotherapy. Another place where rheumatologists may interact with the neurology services, so cyclophosphamide, an alkylating agent, it does penetrate the CSF, though really only when you have some blood-brain barrier disintegrity. Now, another agent that's often used if you fail cyclophosphamide in CNS vasculitis or in these other entities is infliximab. That's a chimeric monoclonal antibody that targets tumor necrosis factor alpha, both in the soluble form and receptor form. Indeed, if you follow the picture there, end of the day, you end up reducing inflammation and pro-inflammatory cytokines through the NF-kappa beta system. Now, here we have, as a rheumatologist, another problem for me as we think of these medications with neuroinflammation. Infliximab really barely penetrates the blood-brain barrier because of its high molecular weight. You'll hear the story over and over again the next couple of minutes. It also has very low lipophilicity, kind of one of my favorite new words in doing this talk. So again, is it mostly work in the periphery and not so much in the parenchyma? So again, as a rheumatologist, are there other ideas that I might bring to the table if I'm part of a team? And indeed, there is some quote unquote novel immunology as we think about primary angiitis of the CNS. There's a sense that potentially in the CSF, if you're able to measure it better, there's a higher level of interleukin-17 in these patients, different than those with stroke or different types of secondary CNS vasculitis. Perhaps these are made by Th17 cells. And indeed, there is a story in other systemic vasculitides, especially those that affect large vessels, such as Takayasu's, that perhaps we can repurpose arthritis medications, such as IL-17 blockers, towards vasculitis. And perhaps that's a similar story in the future in either refractory disease, or as other speakers have told you, what if we could actually get at the precision medicine target in advance before we have to fail agents? There's actually a story here also with another cytokine, which is interleukin-23, which we also have an FDA-approved medication for, which is used in psoriasis and arthritis. Why would we care about IL-17? IL-17 and IL-6 actually are pretty closely tied. And as I'll talk about IL-6 in a second, potentially some synergy there in terms of neuroinflammation. So lastly is my last sort of bucket and case, sort of more targeting of the innate immune system. Another sort of sad case, 6-year-old with fever, sort of an innocuous illness. There really perhaps was a viral illness, then some hallucinations, and then really refractory seizures that could not be fixed. Initially, I thought that this could have been NMDA receptor encephalitis or autoimmune encephalitis, and some of those interventions that are kind of global neuroinflammation dampening. But all that sort of did not pan out. And unfortunately, the child came to our hospital with refractory seizures. They were obviously life-threatening and neurodevastating at times. So this is FIRS, febrile infection-related epilepsy syndrome. It's a subtype of NORSE, or a new onset refractory status epilepticus. And at least in the animal model, there's a sense that this is perhaps driven by interleukin-1 beta. There's a sense that a variety of injuries in the brain may be triggered by the inflammasome or the innate immune system. This entity is still being figured out. Is it a seizure disorder that wigs out the immune system, or an immune dysregulatory process that leads to unchecked seizures? And back in 2016, again, a multidisciplinary group in the Mayo Clinic decided to treat a child with this condition with an IL-1 receptor agonist, Anakinra, which I'll talk about in a second. And indeed, the child had a really great outcome. As you can tell, though, this was started very early. And indeed, there probably is a very short window in terms of dampening the innate immune response as the seizure pathways get propagated. Now, interleukin-1 is hard to measure, but interleukin-6 and 8 are much easier to measure both in research and commercial settings. And those were elevated prior to starting Anakinra in this case report. And as you heard from Dr. Wells, she did comment on the study that I'm one of the lead authors on, and she's also involved in looking at 25 patients throughout the world who had Anakinra with some apparent response to FIRS and safety issues. Again, a great effort, even pre-pandemic, of people coming together of different specialties and different backgrounds. Anakinra is actually a pediatric rheumatology disease powerhouse. It actually mimics an endogenous blocker of interleukin-1. It's utilized in both adult and pediatric conditions, including systemic juvenile arthritis, rheumatic forms of secondary HLH, and even MISC. And then the nice thing about it, immensely short half-life. You don't like it, you take it away. Now, we know it does penetrate the CNS in a variety of animal studies. It is a small peptide. The penetration's not great, but the nice thing is the dose that gets into CSF is much higher than the endogenous levels of CSF interleukin-1 receptor agonist levels. So again, penetration may be variable, but it still might be that some medication can get in the brain and have effects. And in studies looking at rare periodic fever syndromes, such as the neonatal onset multi-inflammatory disease, you can see really nicely the variety of cytokines we can measure seem to go down as we dampen inflammation. with interleukin-1 usage. Now, there are some kids in our cohort, in our sort of retrospective cohort, who did not improve with Anakinra. You might say, are there other medications that target parts of the innate immune system? And there are. So we can block interleukin-6 various ways, including a medication called Tocilizumab, which blocks both membrane-bound and soluble IL-6 receptors. As I'll talk in a second, as Dr. Vanderveer probably talked earlier, it also blocks the JAK-STAT system, so JAK inhibition. Again, this is a very large molecule, about the same size as infliximab. It does not seem to penetrate at all for the same reasons, but perhaps if we're leaky enough, and if we knew we were leaky enough, we can get ourselves into the parenchyma. And for my last sort of couple of slides here, as I go over real briefly, there might be other future targets. As Dr. Vanderveer discussed, JAK inhibition, so tofacitinib, which is an oral agent approved for rheumatoid arthritis, juvenile arthritis, and certain types of inflammatory bowel disease, is small molecule and will cross the blood-brain barrier. And there are reports of its use in refractory autoimmune encephalitis, and this class can also be used in HLH. There are complement blockers, both C5 and C5a of the terminal pathway, which have been approved for a variety of conditions, including neuromyelitis optica. And indeed, one of these, eculizumab, can actually, though it's large, if the complement system is activated, can still cross the blood-brain barrier. And then finally, as you probably heard from our HLH expert, interferon gamma blockade, or emapalumab, can probably be utilized in isolated CNS HLH in addition to systemic HLH. And from the movie Jerry Maguire, the mission statement that got him fired, the things we think and do not say. So I do not know many of you, and my opinions you can take at face value. But I really do believe that working together can lead to improved care. Pathway-driven research, as you've heard today, may unlock future neuroinflammation therapies. Targeted therapies, especially those repurposed from other disorders, are here and now and can be used safely with the right hands and the right teams. We really have to have those teams come together. Our families expect it. They are suffering, and if they are at large institution, they expect that we all really sit at the bedside, figuratively or together, to impact change. And again, for those of you that are entrepreneurs or pathologists, we really need point-of-care diagnostics. And again, I thank you for your time and interest today, and hopefully I can answer any questions. A calm picture, as we still are struggling with uncalm times, though I wish we were there together in person. Thank you again.